Hello, everybody. This is going to be the MDC2 Exam 2 review. It's going to be basically over our oral disorders and part of our esophageal disorders. So we're going to go ahead and start going in. Remember to watch part 1 if you haven't. Oral care. So one prominent oral care disorder is going to be stomatitis. So stomatitis kind of has that itis ending, so it's inflammation in the oral cavity. It can be from a single or multiple ulcer. They may be apophysis ulcers or canker sores. They may be benign or non-contagious. They're going to be very common. It can lead to recurrent ulcers that can be non-cancerous or contagious. There's two types, primary and secondary. So your secondary is going to be usually caused by something else, or like either drugs or an infection. While primary, it's because of the lining. It may be because of chewing. It may be because of breakdown. It may be because of something else, or not an infection. So when we look at our signs and symptoms in our assessment, we need to definitely take a very good history. We want to know about any infections, any nutrition changes, any what they do for oral hygiene. Do they brush their teeth? Do they floss? Do they use mouthwash? What kind of toothpaste they use? We want to know about if there's been oral trauma. Do they play contact sports? Have they had braces before? What kind of stress they have? Any drug history? Do they have any other medical disorders that might co-occur, like bulimia? Does it interfere with swallowing, eating, and communicating is one of the biggest ones, because if they can't swallow, it can lead to aspiration, and if there's a deficit in communication, then they can't communicate their thoughts to others. So often the patient will have a dry, painful mouth with open sores on it. They might have dysphagia. They may have airway obstruction, which airway is going to be key here to have. If they have a candidiasis infection, they'll have white plaque-like regions around their mouth and their tongue. You've seen what candidiasis looks like. It kind of looks like a yeast infection. It's from a fungus. Often it can be wiped away, and it might be red and sore. They might have palpable cervical and submandibular lymph nodes. They might have because they have an infection somewhere. Remember, you want to make sure you complete a swallowing study to confirm involvement of the esophagus, or if there's dysphagia occurring. Remember to use your pen light to look in all areas of the mouth. Remember, you want to pull out the tongue, have the person say, ah. You want to look all the way in the back of the mouth, all the way in the sides of the mouth. You want to look under the lip, above the lip, around the cheeks, under the tongue, all the way in the mouth, because oftentimes you can have these sores hiding anywhere in the mouth, and to be able to do that, we need to treat it effectively. Some interventions that we can do: we can monitor vitals, monitor eyes and O's. Remember, you can assess and position patients to reduce risk of aspiration. Give bland, non-acidic foods and cool liquids, because often acidic foods like citrus, they might be irritating to the mouth. Any spicy foods might be irritating. Hot liquids might irritate it as well, so we want to offer those cool, soothing liquids. You can also give topical anesthetics, and then decrease stress levels, because stress is one key reason why ulcers may form. So decreasing that stress is going to help lower the risk for the ulcers to heal. Our goal here is to restore skin integrity and promote comfort. Some patient teaching we need to do is we need to teach them to adhere to all medications, do not stop taking them, teach about foods to avoid. Remember, no alcohol, irritating foods, or citrus. We need to teach the importance of maintaining intake and output and fluids, teach ways to decrease stress, teach ways to avoid smoking and NSAIDs, because NSAIDs can be irritating, teach about signs and symptoms of infection and what things to report, because if there is an infection and it is occurring more rapidly and is systemic, we need to report that, because that could be a problem. The medications we have, some may be in the form of a mouthwash, some may be topical, some may be oral or in a pill-like form, or liquid. You can use antimicrobials, immune modulators, and symptomatic topical agents, all based on the cause of what's going on in the mouth. So we can use tetracycline, sarocycline, chlorhexidine mouthwash, antibiotics. Aceclopivir is going to be the immune modulator. Nystatin oral suspension can be kind of like that mouthwash. You can use magic mouthwash, which is like lidocaine, Benadryl, bunch of different things to kind of help numb the area almost. You can give them sodium bicarb solution or warm saline solution. Remember, nothing with like alcohol in it. Next thing you have to emphasize to your patient is to have be on top of your oral care, because oral care will help help kind of treat the ulcers and prevent any complications. You can have the UAP do this, but the RN's ultimately that one who's going to double check the mouth after oral care is done. You should usually complete it every 2 hours, and it can also do it after each meal. You can use a soft bristle toothbrush or foam swab. Remember, when brushing the teeth, never go hard at the teeth. Be very gentle. Often they're going to be in a lot of pain. And also, if we have bleeding, that could be a opportunity for infection to enter the bloodstream, and we don't want that. So be very gentle. Remember, you want to have toothpaste free of sodium lauryl sulfate or any alcohols. Remember, they can use mouth rinses every 2 to 3 hours, sodium bicarb, warm saline. Remember, no alcohol content, because alcohol can be irritating. So no irritating mouthwashes. If there's stomatitis, you can remove the dentures, because often with denture use, it can be a reservoir for infection. And if there's inflammation, those dentures can rub against the mouth, and it can cause more irritation to occur. So if there's severe stomatitis or oral pain, we're going to advise the patient not to wear dentures. We definitely want to refer them to the dentist to have an exam. If they're unfunded, we may need social work to help with this, because they need a dental exam to figure out what's going on orally in the mouth, and the dentist is going to be that consult there. Now we go into oral cancer. So oral cancer is going to be affect more than 90% of the epithelial tissues, maybe basal cells or Carpes sarcoma. Usually the easiest sign is you're going to have the erythroplasia in the mouth. It may be on the lips, tongue, buccal mucosa, or the oropharynx. HPV virus may increase risk of development. Of course, increasing age. Smoking and tobacco use and alcohol use places somebody at higher risk for developing it, because these are increasing substances, and age is just something with all cancers. There's 2 different types of these lesions. Leukoplakia. It's going to be slowly developed, thick and white, firmly attached patches on the oral membranes that can't be wiped off. They might be raised and rounded, but they're mostly benign. Lesions on the lips and tongues may be likely to progress to cancer. It's usually from long-term oral mucosa irritation, such as poor-fitting dentures, cheek nibbling, broken or repaired teeth. Hairy leukoplakia, found in patients with HIV. So remember, H may be that hairy leukoplakia if there's a problem with that. Erythroplakia is going to be more your cancerous lesions. So they're going to be red, velvety mucosa lesions on the surface of the oral mucosa. More malignant changes indicates cancer may be occurring. These lesions should be referred for a biopsy. They can be found on the floor of the mouth, tongue, palate, mandibular mucosa, and they can be inflammatory reactions, but sometimes they may not. So we definitely need to get that biopsy to be sure it's actually cancerous. So your assessment, you want to definitely ask if the patient smokes, what work environment they work in, because often toxins can enter the mouth and cause cancer that way. What their oral hygiene regimen is, do they use denture, any oral bleeding, appetite, any dysphagia or weight loss. Remember to, in good lighting, use pen light to assess all the mouth. Note abnormal expansions of cheeks, cuff, tongue movement, voice changes, or absent saliva. Remember to palpate your nose. Assess your patient's self-conduct or concept, because often cancer can be very cause dysfunctional self-image. Oral CDX is a procedure done by brushing lesions to determine cancer, and the biopsy is going to be the number one key in determining all cancers. Some signs and symptoms is they may have mouth bleeding, poor appetite, difficulty swallowing, anorexia, absent saliva, areas that are painless and reddened, or there might be a lump. Remember your nursing interventions ABCs. Remember, airways should always be that first thing you go to if there's any oral problems going on. You want to assess respirations, listen to the lungs, sit them up to help them swallow, and assess for that gag reflex. Encourage fluids. CPT can help. Have that oral solution if they're irritating. Remember, warm saline, kind of like lidocaine. No alcoholic solutions or anything. Radiation can occur and be a treatment. Remember, bradytherapy can also be an option. Remember your procedures with bradytherapy. Chemotherapy can be an option as well. Many medications, the doctor usually prescribe this, but it's an option. Remember, good oral hygiene is going to be the best prognosis here. Remember, every 2 hours, soft toothbrush, no commercial mouthwashes, no acidic foods, no drying effects. Remember, you can use that lidocaine mix or sodium bicarb solution or warm saline. Targeted therapy is another option. Some may need surgical removal, can use cryotherapy, they can be localized. Remember, pre-op teaching and post-op teaching. Remember, post-op teaching should be done in the pre-op. Remember, we want to teach proper oral hygiene, instructions for trach placements, O2 therapy, suctioning, post-op vital monitoring. Remember, they might need a way to communicate if the mouth is going to be really impacted, so that they know how to assist the patient if they can't speak. We want to make sure that there's different ways that we can remove the tumors. Remember, they might need a liquid diet for a day. Definitely airways the number one. They're going to need vitals in the post-op procedure, weight monitoring, INO, pain, difficulty in speech. May need an SLP with swallow studies. Always gentle mouth care. Assess for unusual odors and infection because that might be a problem. You can help with swallowing exercises. Some medications, there's various medications, chemotherapy agents, and then pain meds if they're in that much pain and need to take like an oral dose of codeine or something. I don't know. Some patient teaching points we need to teach them is we need to teach how to take their meds, what foods they should eat, and potential of having impaired taste. You can have seasoning, but no spices. We want to make sure they abstain from alcohol and always read labels on mouthwashes because no alcohol or like lemon glycerin swabs. Teach the potential of adding thickener to fluids if there's difficulty swallowing. You want to make sure that they always inspect their mouth for any changes or bleeding or lesions. Remember, you want to also continue the proper oral care at home after each use. Remember, no sun or tanning beds with certain types of therapies. Use gentle soap. They may need support groups if they need self-image treating. Some other mouth disorders we have are the acute sinusitis. So it's inflammation of salivary glands, post-radiation sinusitis. Salivary gland tumors are rare, slow-glowing, painless masses. Those are just some other things that we can have going on. The thing here is we want to stress that oral care. Remember, soft bristle toothbrush, no alcohol mouthwashes. We want to make sure that they take off their dentures, be gentle with everything, make sure they have a clean toothbrush, etc. And that was kind of it for the mouth disorders. Next, we're going to go into GERD. So GERD results from backward flow of stomach contents into the esophagus. And this is from relaxation of the lower esophageal sphincter. Because of this, acid can come up to the esophagus and irritate the lining of the esophagus. It can result in inflammation and a burning sensation. And if this happens too often, these changes may lead into Barrett's esophagus with the changing structure, which can be an increasing risk for cancer because of tissue dysplasia. It can lead to fibrosis, scarring, and strictures can be very hard to remove, especially if cancer begins to develop. So some of our risk factors is obesity and overweight because of just how the body structure is. Hiatal hernia, which is going to be that protrusion of the stomach or the esophagus. H. pylori infection, lying supine at night, because when they lie supine, it causes the acid to regurgitate into the esophagus, causing irritation. Eating certain types of foods like caffeine, coffee, citrus, tomatoes, peppermint, alcohol, and some medications. We need to know definitely how to assess GERD. So GERD can be asymptomatic in the early stages. The patient may present with difficulty swallowing. They may have dyspepsia or indigestion. They may have regurgitation. They may wake up gasping and gasping for air. They may have nausea, heartburn. They may have dental caries if it's severe enough. They're going to have upper stomach pain. They may have hypersalivation, inflammation of the pharyngitis. They may have pain or bleeding, and bleeding could be a sign of hemorrhage, and that's not good. So some diagnostics we can do to assess for GERD is going to be a barium swallow test, where the patient drinks that white solution and has x-rays of the fluid going through the esophagus to show any abnormalities of the anatomical positions. It's not going to confirm GERD, but can helpful to determine other problems. An EGD is where there's an insertion of the endoscope through the throat to allow the provider to see the esophagus and get a biopsy. pH monitoring is going to be your most accurate way to diagnose GERD, where there's a small catheter and they place it through the nose and attach it to the wall during an EGD, and then the patient has a diary of signs and symptoms over 24 to 48 hours, where the pH is constantly monitoring to a wireless monitoring device. Esophageal mammometry is that water-filled catheter inserted into the patient's nose or mouth, and is slowly withdrawn when there's measurements of the LES and peristalsis. It helps to determine other things, but it won't diagnose GERD. You could do gastric emptying study, where there's radioactive dye, and imaging will show how well the stomach empties in a span of time. And if the food stays inside too much, it can reflux back and cause symptoms. So your treatment here is going to be a lot of your nutrition management and lifestyle changes. Surgery is something that patients who have GERD may not require, but it's usually from complications. So often patients with GERD won't need surgery. It's more about your lifestyle changes. So your nutrition management, remember, you want to eliminate foods that decrease the LES pressure and irritate the tissue. So like no peppermint, chocolate, alcohol, fatty or fried food, caffeine and soda, or acidic foods. Remember, you have to eat about 4 hours before bedtime. Stopping smoking. Small meals 4 to 6 times a day, because large meals may cause that regurgitation. They need to eat slowly and sit up after meals, at least for 1 hour, because it will help that digestion. Some medications we can use are antacids, H2 receptor blocker, and PPIs. Remember, stay away from oral contraceptives, anticholinergics, sedatives, NSAIDs, nitrates, calcium channel blockers, because they can be irritating. So the intent of the treatment here for GERD is to inhibit gastric acid secretions and accelerate gastric emptying to protect the gastric mucosa. So antacids can help to elevate the pH level and deactivate pepsin. It's not good for chronic GERD, but can help relieve those acute symptoms. So remember to take antacids 1 hour before a meal or 2 hours after it. H2 receptor blockers decrease acid, are longer acting, have fewer side effects, and allow for less frequent dosing. PPIs are going to be your main treatment for GERD. They provide long-acting inhibition of gastric acid, and they affect the protein pumps and parietal cells. Some of our patient teaching is going to be similar to our nursing interventions. We need to teach them to limit certain foods, eat 4 to 6 meals a day. Remember, no eating at least 3 to 4 hours prior to bedtime. Eat slowly and chew thoroughly. Definitely, they want to take all medications as indicated and to not stop using them. Weight loss may help. They need to sit up for 1 hour after eating. They may want to not lay flat when they sleep. No NSAIDs. Nothing that will increase the intra-abdominal pressure, no restrictive clothing, and then stopping smoking. It's going to be a lot of your lifestyle changes here. Next, we're going to go on to hiatal hernia. So hiatal hernia is when there's protrusion of the stomach through the esophageal hiatus of the diaphragm into the chest. It's usually from a weakening, allowing for this protrusion to occur. So there's two types of hernias, paraesophageal or rolling hernia. It's when a part of the stomach will extend beyond the diaphragm in a rolling pattern. So it's going to be more like a pouch. It can be from an anatomical defect oftentimes. And then sliding hernias are often the most common. So it's when there's the hernia moves freely and slides out of like chest as like a little part. It's usually from intra-abdominal pressure. The main problem is the complications, and it can cause development of GERD. Some risk factors: aging may cause the diaphragm to become weak. Smoking, obesity, straining, and pregnancy. Some things we need to ask the patient about is heartburn, regurgitation, pain, dysphagia, belching. We need to assess the physical appearance and nutrition habits, and if there's any pain, listen to the lungs. We need to see if pain gets worse lying down. We may need to rule out cardiac issues if there's any feelings of chest pain, even that for GERD. They may need an EKG done. They may need echo done. Who knows? Some signs and symptoms of sliding hernias is going to be heartburn, regurgitation, chest pain, dysphagia and belching. Some of the paraesophageals, feeling of fullness after eating, breathlessness, suffocation, and then chest pain that mimics angina. They may need a barium swallow study, which is essential for diagnosing hiatal hernia. The rolling hernias may be visible when moving the positions when they do the barium swallow. An EJG may be used to view the sliding hernias or any anatomical defects that way. Some of the treatments are going to be similar to GERD. So remember, more sick, smaller meals. Remember certain foods they must avoid. Sitting upright. They need to have the head of the bed up to 6 inches at sleeping. No straining. No restrictive clothing. However, here there's a lot of surgical procedures we can do. So some of our surgical procedures may be like tying it around. They're going to have that Nisa and fundoplication, transsurgical methods, paraesophageal methods. Definitely, there's our thing here is going to be high risk for bleeding post-op, and there might be complications that are needed. Remember, they might need a soft diet for a little bit, anti-reflux medications, no driving, no heavy lifting. They have to do certain dressing changes, report fevers, nausea, bloating, pain, all your post-op stuff that's going on here. Medications, PPIs, antacids, patient teaching. Remember, they need to take medications as ordered. They need to have important nutrition modifications, smaller frequent meals, no straining, report any signs and symptoms of infection. Now we're going to talk a little bit about esophageal cancer. So there's different types of esophageal problems, diverticular or little herniated pouches in the esophagus that can cause complications. Surgery is needed to treat them and to reduce the risk of infection or cancer. Esophageal trauma occurs from chemicals or trauma. One thing we need to do here is if there's chemicals involved, cause poison control. The patient may have vomiting and it cause more issues. So it can also cause trauma, and we don't want that. Esophageal tumors can be benign, but most are going to be malignant, and we need to look for if there's any weight loss. Silent tumors may occur. There may be fears of choking, distress, nutrition problems. They can do an ultrasound, PET scan, CT scan, esophagectomy, and then Barrett's esophagus results from exposure to excess stomach acid and pepsin, leads to that tissue dysplasia. Somebody who has cancer may have dysphagia. All your cancer symptoms, remember those. Those are coming back. Or might have strictures present, orthophagia, regurgitation, vomiting, bad breath, hiccups, chronic cough, increased secretions and infections, hoarseness, anxiety, fear of choking. They need various diagnostics. PET scan is going to show that cancer, and they may need a biopsy. Treatment, chemo, radiation, nutrition therapy. Remember, you may need a speech-language consult. Surgeries to remove entire or part of the esophagus. Some patients may need NG tubes. Remember, you want to check placement every 4 to 8 hours, ensure tube patency, secure it correctly. No irrigation unless there's an order. Head of the bed's got to be in the violet Fowler's position. Evaluate dysphagia and observe for leakage. Remember to protect the family from infection if the patient's going through chemo or using immunosuppressants. So that is going to be part 2 of the MDC2 review, and this is mainly on the oral cancers and the esophageal problems. Okay?